I know I say this every week, two things every week. One, I hope there's no technical difficulties so far. Knock on wood. We're in a really good, smooth start. I have a new program that I'm going to use with this lesson or study session. It's calipers, and I'll kind of show you how they work, but be patient with me because I'm still trying to figure out how it works. I think I got it pretty well though. And then the other thing I say every week is, oh, I forgot what I say every other week. Anyway, okay, here we go. Heart blocks. So we're going to go over first degree, second degree, which has 3 different types, more or less 2 different types, but then sometimes you'll see that there's a 2-to-1 conduction block, but we're going to go over those types in the second degree. We got third degree block. The thing that we're not going to go over is bundle branch blocks. We'll go over that more when we talk about the 12 lead next week. It's a little bit more in depth than I want to go into today. I'm trying to keep these sessions, if I'm just going to be the one talking, it's not going to be interactive. For right now, I just want to keep them a little bit shorter, hour to hour and a half. So if we were to add bundle branch blocks, we'd be in it at like 2-hour study sessions. And I know everyone probably doesn't want to stick with me for 2 hours. So we'll save bundle branch blocks for next week when we talk about 12 leads. Unless somebody wants to talk about something else. All right, so let's review over real quick a little bit from last week about EKGs, basic EKGs. So EKGs or ECGs, electrocardiograms, they are a snapshot. It's a picture of the electrical activity of the heart. Now, with the electrical activity of the heart, that picture, and the assessment of the heart that you have, like listening to lung sound or listening to heart sounds, echocardiograms where they take an ultrasound and look at the different structures of the heart. It all provides us a better picture of the heart from where we are. You know, we can't cut open everyone's chest to see what's really going on. So this gives us a snapshot of some of the things that we are seeing with the heart, along with heart sounds and whatnot. So EKGs are the electrical activity of the heart. I already said that. Okay. So this here is a basic layout of an EKG. Yeah, what's going on? Where's my laser pointer? Okay, so every normal EKG, you're going to have a P wave. Hold on 1 second. Okay, every normal EKG is going to have a P wave, a QRS. I don't know why this is so delayed. I need to bring it closer. And then I need to bring it a little closer. And then a T wave. And sometimes you'll have this U wave. I don't know. It's like a congratulations, we're restarting. So P, QRS, and T. That should be part of your EKG rhythm for normal rhythms and conditions with the heart. What do these all mean? Let me go through here. I set it up wrong. Okay, so your P wave, that's gonna mean atrial depolarization. That means that we're depolarizing, we're having atrial contraction, pushing blood into the ventricles. Then we go to our QRS, which is the ventricle depolarization, the bottom part of the heart. It depolarizes, it contracts and pushes the blood out of the heart. Your T wave is repolarization of the ventricles. Okay, So the different parts of these EKGs tells us what's going on in the heart during that time, depending on the length of your waves. Also the length between the waves. So we have the PR segment, which is this here to this here. And what that tells us is that's where it comes from. The electrical signal starts in the atria. It travels down to the AV node, the atrioventricular node, and it pauses there for a minute, kind of like a train. You gotta check your tickets at the AV node, and then it sends it down to the ventricles. Okay. And then last but not least, the line that's flat here in between each cardiac cycle is the isoelectric line. Why is that important? We're going to talk more about this with the 12 lead, but that's important because if you have an elevation with your ST, you know, your T doesn't come back down to baseline here. That means that you may have some, or you do have some ischemia going on in your heart. The other thing is amplitude. So the higher these waves are from the isoelectric line of the heart, the more amplitude that electrical activity has. So how do you measure time with this? So time goes across horizontally, and each one of these little squares is a unit of time. So we got a small square that equals 0.04 of a second. Then we've got 5 of those squares together equals 0.2 seconds. Then we got 5 of the large squares. So 5 of these guys, 5 of those guys equal 1 second. 15 large equals 3 seconds, and then 300 is 6 seconds. And usually most of your strips, if you're ever taking a test or anything, most of your strips will be a 6-second strip. So you get a minute of a heart rhythm. All right, so what are normal intervals? One that we really want to pay attention to when we talk about blocks for this study session is the PR interval, and the normal for that is 0.12 to 0.2 seconds. And that's about 3 to 5 small squares. And that's something that you're going to want to just tuck in the back of your head, because it's really important when we start looking at rhythms that you know your PR interval. When we start going into bundle branch blocks, then we'll talk about QRS, because the wider that is, we can start figuring out bundle branch blocks. But for right now, we want to make sure that the PR interval is 0.12 to 0.2 seconds. Tuck that away, because you're going to need it. So what does this look like? As you can see, we're going to go slowly through this heart. So here's the SA node up here. It pushes the electrical activity, so this is depolarization with the P wave. It causes the atria to contract. It pushes the blood into the ventricles here. And as they do that, a signal, electrical signal, travels from the SA node down to the AV node. Check the tickets there, and then it sends the signal down into the ventricles to depolarize it, which is the QRS, cause it to contract, and then the whole heart resets. So one whole cardiac cycle is depolarizing atria's contraction. Blood pushes down to the ventricles as the electrical conduction goes to the AV node, takes a little pause, and then it gets sent down to the ventricles that are filled with blood to be able to contract, push the blood out of the heart, and then T wave, we reset. Sometimes I lay awake at night thinking about the cardiac cycle because I'm a nerd, and I just think about all the fillings of the blood and the EKG rhythm. It's relaxing. It's like meditation, I guess. But yeah, it helps me fall asleep at night. It's so interesting. It's cool. All right. So we're going to go over very briefly normal sinus rhythm. So your normal sinus rhythm, you're going to have a P wave, a QRS, and a T wave. This here is not, this is exaggerated. These are very wide, but it's to show you this is what a normal sinus rhythm should have. Down here on this rhythm strip is what a normal sinus rhythm strip would look like. It's not, if you see, the QRS is not wide, the P wave is not wide. The P wave is nice and close to the QRS. You got this nice T wave here. Everything looks the same and everything is regular. Now I'm going to pull out these calipers. I'm so excited about them. So last week I talked about having calipers that you can march out the QRSs to see if a rhythm is regular. So if you have calipers, usually in the hospital, when you have your monitor that has all the rhythms, you can pull up a rhythm and they have a calipers already built into the system. I know we use Philips right now. We just switched over. We used to have Draeger, and even the old Draegers from caveman times had calipers, electronic calipers built into the system. So take a look at that. Take a look at wherever you're at. Even if you're at a hospital doing clinicals, just pick the minds of someone. Say, hey, can you just show me where the calipers are? And you can pull someone's rhythm up and just kind of measure things out and march things out. All right, so I'm gonna set this real quick. I learned that I have to calibrate this every time I use it, but I made it a little bit quicker. That pointing. Okay. All right. So first, let's measure the PR interval. So we start at the beginning of the P wave to the start of the QRS. So this is 0.14 seconds. What is normal? Is that normal? It needs to be under 0.2 seconds, right? So that's normal. We don't want that long. Now, if we wanted to march these out, what you would do to see if they're regular or not is you take these calipers, your electronic calipers, and you go to you spread them out to one QRS to another QRS. And then on this program, I can do marching caliper. And what it'll do is it should line up with each other. There you go. It looks like it's speeding up actually. This also has the function that you can figure out your rate, but I have to figure that out. Maybe by next week I'll have that figured out. So anyway, this looks like it's speeding up a little bit, but normal sinus rhythm, you're going to have your P wave, your QRS, and your T wave. Your rhythm will be regular. Every distance between the QRSs will be the same if you march it out. P waves will be the same if you march it out, and every P wave has a QRS. They're married. This is just to remind us 0.12 to 0.2. If you can't remember ranges like that, just remember your P wave has to be less than 0.2 seconds. Remember, less than 0.2 seconds, and you'll be fine. All right, what did I hit there? All right, so now we're gonna get into heart blocks. There's a couple different ways that you can remember these. One is a heart block poem, and then one is a analogy with marriage. So we'll start with the heart block poem. The reason why I like to go over different ways to learn them is because it makes it easier for some people to learn one way versus another. Some people can just memorize it. I can't memorize it. I have to understand what's going on. I also have to use analogies a lot. So we're going to go over this again and throughout the study session so that we can break it down. But here's the heart block poem. If the R is far from P, then you have first degree. If your R is far from P, you have first degree. Longer, longer, drop, then you have Winky Bach. And sometimes you have longer, longer, longer drop, but longer, longer, longer drop, then you have Winky Bach. And Winky Bach is Mobitz 1, second degree Mobitz 1. If some P's don't get through, if some of the P waves don't talk to the ventricles, it doesn't send the signal down because the AV node is like, bah, your ticket is invalid. If some P's don't go through, then you have Mobitz 2. If P's and Q's don't agree, then you have third degree. Third degree is complete heart block. The conduction systems are not talking to each other. The AV node is completely shut down. That train station is out of order. You need to go somewhere else. So if P's and Q's don't agree, you have third degree. Now the other way we can talk about it is we can look at it like the P's and the QRS's are married. Okay? So normal sinus rhythm, the wife, which is the P wave, and the husband, the QRS, are married. And it could be whatever couple. So the couple is married, and your QRS, they come home every day, they come home at night, they come home on time, they have dinner, they can't be apart from each other, they love themselves, they love each other so much, they are always together. So every P wave has a QRS. We're in normal sinus rhythm. All right, so now we have first degree block. So now the honeymoon phase is over, right? The P wave is waiting at home, and the QRS just comes later and later. Every night they come later. So there is a delay between the P and the QRS because there's time that they are being separated. So every P wave has a QRS because he's still coming home. The QRS is still coming home to the P wave, but he's coming home late. So second degree, our relationship is getting a little bit rocky. The P wave is always there. She's waiting. The P wave is waiting there at home. And the QRS this is type 1, the Winky Bach. The QRS comes home later, until one day he decides he's not going to come home. But the P wave is always there. So the P wave is there, the QRS waits longer and longer, he gets home later and later until finally he just doesn't come home. So second degree type 2 is when we don't know if the QRS is coming home or not. P wave is always there. P wave is waiting at home, has dinner on the table. We're trying to, greet our QRS at the door. And sometimes the QRS comes home and sometimes the QRS doesn't. And when he does come home, it's the same time, but we just don't know when he's going to come home. So in second degree type 2, you have a P wave, QRS, P wave, QRS, P wave, P wave, P wave, QRS. So not all the time will that QRS come home. We just don't know. But P wave is always there. In third degree AV block, P wave has had enough. They are now completely separated. They are on their way to a divorce. So P wave is no longer waiting around. P wave is like, you know what, if you're not going to come home on time, I'm just going to go off. I'm going to do my own thing. I'm going to live my life. So she goes and does, whatever she wants to do for her life. And the QRS is doing their own thing. So they're no longer communicating to each other whatsoever. They are done. So the P wave is going to be doing their own thing. And if you look at the rhythm strip and you march out the P waves, they're going to be equal distance, doing their own thing. And the QRS is going to be doing their own thing. If you march out the QRS, they're going to be evenly spaced from each other. So P wave is evenly spaced from P wave, QRS is evenly spaced from QRS, but they don't line up. Not every P wave has a QRS, and sometimes your P wave is meshed into the QRS. And we'll take a look at that. So now let's get into it. Kind of keep that in the back of your mind. All right, so first degree block. There's no disruption, like there's no complete block in the electrical conduction. There's just a delay. In this delay, the train is leaving the SA node, comes down to the AV node, and the AV node is taking their sweet time checking all the tickets of the electrical activity till finally it says, all right, everyone's good, and it releases that electrical activity to the ventricles. But every signal from the SA node gets sent down. There's not any that just gets rejected. So in first degree block, your PR interval is going to be greater than 2 seconds. So remember, if we think of our poem, we're going to see, I didn't learn it with the poem, so I have to refer to it. If the R is far from P, then you have first degree. So you have a greater than 2 second PR interval. And the other thing is that every P wave has a QRS. It's very, very easy to confuse this with normal sinus. If you look at something right off the bat and you don't have calipers on you, you can't read the little squares to figure out how much time is actually being spent between the P and the R, then sometimes if it's not close, like it's not 0.21 seconds, you can say, okay, that's a normal sinus. The P wave is really close to that QRS. Or sometimes you can say, oh, that PR, the P wave is far away from the QRS. But for the most part, you want to try your best to find a way to measure it. So what can cause first degree block? Well, electrolytes, sometimes with age can cause it. Some athletes have it. Myocardial infarction, so when you have a heart attack, that can cause it because you can't really get electrical activity through scar tissue. It's not very good. Or dead tissue. It's not a good conduction. And then inflammation and infections can also cause the PR interval to be longer. A lot of times, if the PR interval is not super long, then you won't have any symptoms. You'll just have a routine heart check for sports, or if you're flying and you need a flight physical, sometimes the doctor will notice it on EKG and you just need to monitor it. The thing that we get in trouble with is if that PR interval gets longer and longer, we can start going into more dangerous rhythms and dangerous blocks. So that's why you want to keep an eye on it, but for the most part, you don't really have any symptoms with this. Okay, so what does it look like? As you can see here, it'll come down, it gets delayed, and then it will continue the electrical activity to the ventricles. So the AV node here is just taking their sweet time checking tickets of the electrical activity. Okay, what does the rhythm strip look like? Looks like sinus rhythm, doesn't it? Looks like normal sinus rhythm. However, let's get our calipers out here. Let me calibrate them real quick. That's one thing about this is I have to calibrate it every time I use it, but it shouldn't be too long. Okay, we measure from the beginning of the P wave to the beginning of the QRS, and what do you know? It's 0.29 seconds, so almost 0.3 seconds apart, which means it's first degree block. What's normal PR interval? Anything less than 0.2. So this is above 0.2, so we got ourselves some first degree blocks. All right, let's look at a couple different rhythms here. Pull our calipers back over. All right, this is also first degree block, so we go ahead, put our calipers up there. Let's adjust it. Here we got 0.23. We have P waves, right? This is a T wave. They're inverted. So P wave, QRS, T. We have all the parts of a normal EKG. However, this PR interval is long at 0.23 seconds. Let's look at this one. Wow, this is really long. This is one of those that you can see on the monitor and be like, oh, man, that's a lengthy PR interval. All right, let's get our calipers up here. Now, normally you should calibrate your calipers every time you use it, but I don't want to waste the time doing that. They all should be similar. 0.53 seconds. That's actually probably not correct here. If I were to calibrate it. Okay. Let's measure this out with this new rhythm strip. So 0.36, that's greater than 0.2. We have our P waves, QRS, and Ts, but that is very long. This is probably one that we need to really watch to make sure it doesn't get any longer. All right, here's this one. I want to get some funky looking rhythms so that way, because not every rhythm is going to look textbook. You're going to have some that looks really weird, but as long as you can distinguish the different parts of your waves, then you'll still be able to figure out what rhythm it is. So here we've got P's, QRS's, and T's. Right? P's, QRS's, and T's. This, don't worry about this for right now. This could be the isoelectric line, and we just have some elevation here with some ischemia. This person may have had a heart attack in a certain area of their heart. We just don't know. We just need to figure out what kind of block this is, or if it's a normal rhythm. So let's get our calipers over here. Let me go ahead and calibrate it right quick. I'm trying to do better too to look at the chat to make sure I'm not missing anybody's questions. All right. Beginning of the P wave, beginning of the QRS. We got 0.21. So it looks pretty, it looks like, if you just look at it, it looks long. Remember, your P wave is supposed to be really close to your QRS. So looking at it, it looks pretty long. But the number 0.23 is pretty close to 0.2, but it is over 0.2. So there you go, first degree block. So first degree block, QRS is getting tired of coming home to P. So he stays out later and later, but he still comes home. All right, second degree block. So there are a few types. We've got Mobitz 1, Winky Bach, and this is my favorite second degree block. So the way I differentiate Mobitz 1 and Mobitz 2 is my favorite is number 1. And I'll explain why it's my favorite. I don't know why, it just interests me. And then we got Mobitz 2. Mobitz 2 is dangerous, and we'll see when we look at the rhythm. And then we have a 2-to-1 AV block. And the 2-to-1 conduction block is where you have every other P wave dropping a beat. So let's go back to Mobitz 1, my favorite. It's also known Winky Box. I don't exactly know why. I think Dr. Winky Box discovered it. I don't know who discovered Mobitz 2, but at any rate, in Winky Box, your PR interval is normal, then it gets longer, and then it just drops. There's no QRS. So if you look at the marriage analogy, you've got P and QRS. QRS comes home, then he stays out later, stays out a little later, and then he just doesn't come home one night. And then he comes home on time. Maybe P wave yelled at him and said, "Why didn't you come home at night? I made dinner. We had pot roast." So we've got P and QRS. QRS comes home, then he stays out later, and then he doesn't come home. And he repeats that cycle. Mobitz 2 is similar to Mobitz 1, but instead of that getting longer and longer, it just drops. So he got yelled at, so now he's going to come home at the same time every night, but then one night he just decides, I'm going to stay out all night. And then he gets in trouble, so he starts coming home, and everything's fine. Then another night, he just decides not to come home. So there's no lengthening with P and between the P and R. It just suddenly drops. The P wave just doesn't have a QRS. And if we think about the poem, let me pull the poem up here. For Mobitz 1, For Mobitz 1, longer drop, then you have Winky Block, my favorite second degree block out of the two. And then Mobitz 2 is, if some P's don't get through, then you have Mobitz 2. So what does that look like? Oh, I'm sorry. Symptoms. So these patients, they're going to have chest pain. They're going to have some lightheadedness, faintness, because since not all of the P waves have QRSs, those ventricles are not contracting. So you have a lower heart rate than what you would have normally. They may feel tired or short of breath, and all of this is because they're just not getting enough blood flow because the heart isn't beating normally. What are causes? Well, we've got the aging process. Aging sucks. Aging sucks. It makes everything go weird. Damage to the heart, whether it's from surgery, a heart attack or ischemia, or some sort of disease process, congestive heart failure, atherosclerosis. Low thyroid levels can also do this. Electrolyte abnormalities, rheumatic fever, and sarcoidosis. So rheumatic fever is when, at least what I was taught is that when you have strep throat and it doesn't get treated properly, you can develop rheumatic fever that can affect the heart, and it causes a little bit stiffening of the heart. And then we got sarcoidosis, which is an autoimmune disorder, which also it causes tissue to become hardened. And you can see these patients, their skin is often very tough. And then some medicines can also cause second degree block. All right, now I think we go to see what it looks like. Patients, especially with the Mobitz 2, they're going to need a pacemaker, a permanent pacemaker, because their heart rate is just too low. Their ventricles are contracting at too low a rate, and that will cause them to pass out, not get enough blood flow. So what does this look like? So if you see here, here's the SA node. It sends that signal, but it gets delayed. And this is type 1. It gets delayed. Then it sends it out. Then the next time it gets delayed a little bit longer. Then it sends it out. And then it blocks it. That flashing is that one of the signals just doesn't get through. So we got a P wave. And that flashing means that that P wave didn't get to the ventricle. This is what it looks like. If you see here, here's this PR interval, nice and close up here. Nice and close, got a little bit longer, and then all of a sudden there's no QRS. There's a P wave, but no QRS. Then we start over. We've got P and R nice and close together, P and R a little bit longer, and then this one won't have a QRS. If we get our calipers out, you'll be able to see. Do I have my transparent one still? No. Let's do this P wave here. So as you see here, it's 0.2. If you go over to this PR interval, it's longer. It's not 0.2. Oop. This one is 0.29. Then we come over to this one. We've got We've got 0.3, and then this one doesn't have one. So longer drop, then you have Winky Bach. QRS gets home later and later at night until P wave is at home alone because QRS decided not to come home that night. Let's look at a couple other rhythms. I'm not going to pull up my calipers for this because we can kind of see it. Here you got P, QRS pretty close together. It's probably a little bit longer. But then we see here, it gets longer, even longer. And then here's a P wave, but no QRS. So we have QRSs, we have P waves. Does every P wave have a QRS? Nope. Not every P wave has a QRS. So we've got a heart block. Which heart block? Well, we've got P and R, okay here. Gets longer, and then we have a drop. So this is Mobitz 2, or Mobitz 1, I'm sorry, Mobitz 1. Let's look at this one. This one is a little bit harder. If we got our calipers out, we would see it. But here, we've got a lengthened PR. We got an even longer PR. Got a longer PR, and then here's a longer PR, and then we got a P wave. So this one has 1, 2, 3, 4 longers, and then all of a sudden it just drops. And then the cycle starts over. So every P wave has a QRS except for one, which means we have a block then. We have the AV node is not letting one of the P waves get to the ventricles. We got to figure out which block it is. Look at the PR intervals. They get longer and longer until finally there's a P wave with no QRS. Winky Bach. And last one, you can see here, nice and close, longer, and then a drop. Here's nice, close together. This one is longer, and then there's drop. And here you can see they measured out the PR intervals for you, so you can see how it gets longer. All right, Mobitz 2. This is where it becomes dangerous because if you look at this strip here, up here, look at this strip. So we have 1, 2, 3, 4, 5. So we have at least a heart rate of 50, right? Our ventricles are contracting at least 50 times a minute. You can live with 50. We have to intervene and do something, but you can live with 50 beats per minute. Now look at this. Now we're at 30 because not all of those P waves are coming through. So now we've got 30. We've got the ventricles contracting 30 times a minute. That's a lot of loss of blood flow. So what is Mobitz 2? Well, you got P and QRS equal. Here you go. They're equal together. If we were to measure with calipers, this distance between this P and R would be the same distance between this P and R and this P and R. However, some of these P waves, you can see, some of these P waves don't have QRSs. So we have Mobitz 2. If some P's don't get through, then you have Mobitz 2. So if some of those electrical conductions do not get through that AV node, it just stops right there. But once in a while, the AV node likes the tickets of the electrical conduction, it'll let it through. But not all the P's are getting QRSs. They're not getting to the ventricles. That electrical conduction is not getting there. So you have Mobitz 2. Let's look at a couple more of those. See, all the PR intervals are very similar. They should be exactly alike, but then there's a P wave that doesn't have QRSs. Here's this one's missing and this one's missing. This one looks a little weird, but don't panic. Here's P waves. Here's a P wave. Here's a P wave. Here's a P wave. Here's a P wave. Does every P wave have a QRS? No. Here's a P wave without a QRS. So we got a block. Here's another P wave without a QRS. We've got a block. Which one is it? Is the PR intervals the same? If we took our calipers out, they'd be the same, right? If we march out the intervals, it should be the same. These P waves are hard to find. Okay. 0.0, 0.2, 0.2, 0.2. So they're all the same. It just, some P waves don't have QRSs, which means that we have a block. Since the PR intervals are the same, we've got type 2. I think I like type 1 more because it's more interesting. There's more going on. You know, your PR interval's getting longer and then it drops. This is boring. You know, your PR intervals are the same. I think that's why I like Mobitz 1 more. Ah. All right. This one here, the person may be able to get by a little bit more, but we never know when those P waves are going to get a QRS. So you want to make sure that we treat this person right away. Now look at this one. This one is also super low heart rate. Here is 30. Look at all these P waves. See all these P waves? Only 1 out of 3 are getting through here. Look. So these P waves are like, hey, come on, come home, come home. The QRS is like, no. And all right, fine, I'll come home. So PR intervals look like they're the same. We just have some P waves not getting QRSs. So if the P's don't get through, then you have Mobitz 2. All right. I'm going to just show you one rhythm for the 2-1 block, conduction block. Some people in ACLS, they don't always go over this, but I do want to kind of show you. We're not going to have any questions on it. I want to show you in case you do hear it mentioned that you're already familiar with it because you learned it here on Twitchy Nurse. So what that looks like is this. If you see, every other P wave has a QRS, and then every other P wave does not have a QRS. That's what I meant to say. So we have a P, QRS, P, no QRS, P, QRS, P, no QRS. And that same rhythm all the way down. That same pattern. So a 2-to-1 conduction block is a second-degree block. Not every P goes through, but it just means that every other P doesn't go through. Again, you don't really, you don't really get tested on this. I've never been tested on a 2-to-1 block. But it's good to know that it is out there and it is talked about. All right, 3rd degree heart block. Yeah. All right, so what does this look like? Well, when you march out your P waves, and we'll look at a strip and I'll show you. If you march out your P waves, they all have equal distance between each of the P waves. Then when you march out your QRSs, they all march out and they have equal distance between them. However, I didn't mean to spell cinch. I meant to say sync. Put an H in there. Okay, wanted it to be spicy. So the difference between normal sinus and 3rd degree block is that they don't match up. P waves are doing their thing, QRS is doing their thing because the AV node is donezo. The AV node is done. It's not conducting anything. The train station is shut down. We are not checking tickets. We are not conducting electrical trains through here. We're done. So the atrias are doing their thing, the ventricles are doing their thing, and it's not always synchronized. That didn't make any sense. My hand motion. Okay, so what are some symptoms of this? Chest pain, lightheadedness, faintness or dizziness, feeling tired, short of breath. I had one patient, the doctor thinks that she went into 3rd degree heart block. What I saw on the monitor was a VFib. I was new to the ICU, but I pulled in another nurse and I was like, hey, you know, something's not right here. She was gasping for air and she was in and out of consciousness. So we ended up coding this lady and doing chest compressions and everything. And there was, we didn't have time to do a 12 lead. A 12 lead would definitely tell us if we were in a 3rd degree heart block or asystole. But the doctor said that he thought that it was a 3rd degree heart block. And looking back, in the situation, I was very adamant that I saw VFib on our monitor. And when we pulled up the strip, it also looked like VFib. I didn't really see the 3rd degree heart block. But if you looked at the patient, I could see why you would think that that was 3rd degree heart block, because she was gasping for air. So anyway, that was my only experience with a patient with 3rd degree heart block. I haven't really had another patient with it. I had a lot of patients that was severely bradycardic, but never one that had 3rd degree heart block except for that one. So what causes this? Again, pretty much the same thing as type 2 or 2nd degree. Damage to the heart muscle, heart valve disease, rheumatic fever, sarcoidosis, scarring, dead tissue doesn't conduct electricity very well. Some medications can do it, and some blocks can progress to 3rd degree heart block. That Mobitz type 2 can progress to 3rd degree heart block, and if that PR interval gets longer in 1st degree, it can also go on to become 3rd degree heart block. So this is a very dangerous rhythm, and you want to make sure that we get our patients out of it. So what do these patients need? We need to stop the causes. So if they have an infection going on, we need to fix that. Most likely these patients are going to be on a permanent pacemaker. You can pace these patients temporarily. It's pretty uncomfortable. What you can do is you can put the pads, the defib pads on them, and you can trace them through their skin. You can also, if they are intubated, you can also do what's called a tap scope, where you put a device through their mouth and it'll sit behind the heart and the esophagus, and they can pace the heart from behind the esophagus. Just send little electrical impulses that'll make the heart beat. So what does this look like? So as you can see here I couldn't find a animation, so you're going to have to watch my laser point. I wish I could change the color because the heart is blue. I wonder if I can. No, I can't. All right, you're going to have to deal with a red laser pointer. So here's the SA node up here. It's sending signals to this AV node, but like I said, the station is shut down. So there's no communication between the top part of the electrical activity and the bottom. So these guys down here, because remember, any part of the heart can generate electrical activity. The ventricles are producing their own electrical activity, and the SA node is producing their own electrical activity, and there's no communication between the two. This is where the P wave and the QRS wave are completely separated. They don't talk to each other. They're living their own lives, and they got nothing to do with each other anymore. They are done. And then if you want to go by the poem, if P's and Q's don't agree, then you have third degree. All right, so let's pull those calipers out again. Yeah. Pull them out. All right. We're going to add 2 calipers here. I'm going to go to the center of this P wave. I'm not going to worry about calibrating these because I want you just to see them marched out. In the center of that P wave. Let's march it out. I wonder if I can... Actually, let me add another caliper. We'll make this one green. Ah, I can't see it. How about purple? Purple good? Yeah, there. It looks close to blue. Okay. Tried and true. All right. Purple and red. So P waves march out. Get put there. Let's get this caliper on each of the QRSs. There we go. Now let's march out the P waves. So P wave here, P wave is hidden in that T wave, P wave, and then if we were to extend this out, P wave. We move this over. Oop. P wave, P wave. All right, now we look at the QRSs. Let's march out the QRSs here. There. Now QRSs are marched out. They're doing their own thing. See? They all match up. So, every P wave does not have a QRS. Some of the P waves are even hidden, but if you march out your P waves, this purple line, they all match up. If you march out your QRSs, they all match up. They all have equal distance from each other. So you got third degree heart block. No communication. Let's look at a couple other examples. You better intervene with this patient. It's no bueno. Let's march these out. Yeah, let's march them out. I think if we were to, it's not going to work very well. We're not going to be able to use these calipers, I don't think. Let me see. I don't know if I can extend this window. Oh, I can. Oh, very good. All right, let's march these out. I think this is a P wave over here, so we'll do P wave, P wave. We're going to add another caliper. We'll do QRS, QRS. Let's march out this guy first. So you can see this, you got P wave, P wave, P wave, and P wave. Now let's go ahead and march this guy out. This is going to be harder because we don't have another QRS in this rhythm strip. But your PRs mark out and your QRSs mark out. But if you see, there's no P wave before this QRS and there's no QRS after this P wave. So they're doing their own thing. Let's see. Next. Bring this down here. Okay. Let's measure this up to the P waves. And then this will march up to the QRSs. Get this over here. There. So you see P wave, P wave, P wave. Oh, this is a P wave here. Where's that other P wave? I'm going to do this. There we go. Okay. Oh, this is good. Okay. P wave. The P wave is hidden in this T wave, QRS T wave. P wave, P wave, P wave hidden in the T. P wave hidden in QRS. And then we got the QRSs, and they march out pretty well. QRS, QRS, QRS. Completely not talking to each other. So we've got third degree heart block. Last example. Let's move this to the P's. Okay, and then move this one to, this one we're gonna actually get rid of this one. We'll just leave it. This one we're also not gonna be able to march out the QRSs because there's only 2. So if this is a 6-second strip, so this guy had a heartbeat of 20 and this guy had a heartbeat of 20 as well. But our P waves, if we look at the red here, here's a P wave hidden in this T wave depression. Here's a P wave hidden here, P wave. So we're actually a little more extended. There we go. Okay, so third degree heart block. All right, so I'll leave this up for just a little bit. If you pick one of these things to remember your heart blocks with, you won't go wrong. So pick either the heart block poem or the AV block family, and figure out which one works best for you to remember these, and then you will never get one wrong again. Once I adopted one of these, I always got my rhythms right. It was just user error most of the time, clicking on the wrong thing. All right. Let's go with questions. So this is a matching one. We're going to match the rhythms with what they are. Whoops. Okay. So here's this one. Let's go back to how we read our EKG strips from 2 weeks ago. Is there P waves? Yep, there's P waves. See all those little bumps? Do we have QRSs? Yep, we have QRSs. Does every P wave have a QRS? Nope. You see that? These P waves don't have QRSs. They're just P waves. So what does that mean we have? Well, the P waves are not getting into the ventricles. So we've got a second degree, right? And there's a couple of versions of second degree. So we have to figure out what degree it is, or what type it is in the degrees. So if you remember our heart block poem, some P's don't get through, then you have Mobitz 2. longer drop, then you have Winky Bach. Or if you think about the marriage analogy, P wave is sitting at home all the time, and QRS decides when he comes home. Sometimes he comes later and later and later, and then he doesn't come home. That's Mobus 2 or Mobus 1. And then sometimes he decides to come home randomly at random times. So what do we have? I would say the PRs are pretty even when they do have QRSs. We're just dropping beats, right? So which one is that? If you said, what color should I use? This blue. If you said type 2, you are correct. Yay. All right. What is this one? Do we have P waves? Yeah, they're there. See, little bumps. Do we have QRSs? Yep. We have QRSs. Does every P wave have a QRS? No. Does it look like they're together at all? Not really. Let's pull our calipers out. I'm going to get a fresh one. Put it on this window here. All right, we're going to add a caliper. Let's march out our P waves first. Make P waves red. March them out. So P wave, P wave, P wave in this T, P wave, P wave, P wave in this T, P wave, P wave, P wave. All right, let's add a blue caliper for our QRSs. Oops. I didn't mean to do that. There. Okay. March those out. Every blue line is at a QRS. See that? So they are doing their thing. So what kind of block is that? There's no communication between the top and the bottom part of electrical activity. So it's a complete dissociation from each other. So if you said complete heart block or third degree heart block, you would be correct. Chunk. These are too close together for me to do the lines. All right, next one. Do we have P waves? Yep. P, 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 P. Do we have QRSs? QRS, 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 QRS. Does every P wave have a QRS? Sure does look like it. All right. Are they regular? Is the rhythm regular? We can find out. Oh. What did I do? Let's do the QRSs. Let's march it out. Yep, it's regular. All right, now let's see the PR interval, because now we don't know if it's normal sinus or if it's a block. All right, let's calibrate this puppy. All right, and we measure the PR interval, 0.13. Less than 0.2, you're good to go. So what rhythm is this? If you said normal sinus, you are correct. Burp, burp. Okay. This one. All right, we have P waves, right? Here are some P waves. Here's our QRSs. every P wave has a QRS. It looks regular to me. What is the PR interval? That's what's going to tell us if it's a first degree or if it's, oh, I need to pull out my calipers again. First degree or if it's regular, normal sinus, right? Never guess. If you have the ability to use calipers on a test, use it. Don't ever guess, because the time that you guess wrong, you get it wrong, and then you have to do over. We used to do a rhythm test at work. This is the first year where we don't have to do a rhythm test, and I would always fail because I didn't slow down and look at what I was doing and think. And I would miss first degree blocks. I would miss type 2 block or second degree type 2 blocks. So slow down, use your calipers if you have it. So this is 0.22 seconds. So anything greater than 0.2 is a elongated PR interval, which would be which block? There is a block because the signal's getting slowed down. If you said first degree, you are a winner. You can now become a cardiac nurse. All right, here's my favorite one. We can say that this is the last one at second degree type 1, but what if they duplicated one of these? So let's take a look. Are there P waves? Yep, there's P waves. There's QRSs. Does every P wave have a QRS? Nope, look, here's a P wave with that one. Here's a P wave with that one. Here's a P wave with that one. All right, so we've got a block. Not all the P's are getting through, so we have a second degree block. So it's irregular, so we know it's second degree, it's not third degree. So let's see what the PR intervals are. Here it's nice and close, gets longer, and then it drops. Short, longer, longer, drop. Longer, 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 drop, then you have Winky Bach, type 1. Clear as mud, looks like a tangled mess. If this was IV tubing, it'd be really bad news for it in the ICU. We do not like tangled tubing, let me tell you. All right, so we've got second degree type 2 at the top here. Let me get my laser pointer. Second degree type 2 up here at the top. We've got third degree block here, second strip. We've got normal sinus as our third strip. We have first degree heart block as our fourth strip, and our fifth strip is second degree type 1. All right, an ECG is performed and reveals a progressively increasing PR interval and dropping of QRS complexes at regular intervals. Which of the following is the most likely diagnosis? There's no NCLEX or CCRN or TCRN questions in this. This is strictly just rhythms. All right, so let's look at the answers. Second degree heart block, Mobitz 1. Yeah. First degree heart block, second degree heart block, Mobitz 2. Hyperkalemia. All right, so what can we gather from this question? What information does it provide? Well, it reveals a progressively increasing PR interval and dropping of QRS complexes at regular intervals. Which of the following is the most likely diagnosis? So we've got a dropping going on. We're dropping some beats. What block drops beats? If you said second degree, you would be correct. So we can get rid of B. And hyperkalemia is going to have a peaked T wave, I believe. Peaked P or T. I can't remember right off the top of my head. At any rate, it's not second degree, so let's get rid of that. So now we got to figure out if it's 1 or 2. So which one has the progressively increasing PR interval? If you remember the poem, longer, longer, longer drop, then you have Winky Bach. if not all the P's go through, then you have Mobitz 2. So if it gets longer and longer and longer, drops, then we've got Winky Bach, which is 1. So if you said second degree, Mobitz 1, you're good to go. Okay. What PR interval indicates first degree heart block? Do you remember the PR interval? You really only had to memorize one number. Anything less than 0.2 is a normal PR interval. So we need to remember that. Let's look at our answers. 0.12 to 0.2, greater than 0.1, that should be less than 0.1. Less than 0.12, I may have screwed up this question. Greater than 0.2, I didn't. This should be less than 0.1. 0.12 to 0.2, less than 0.1, less than 0.12, or greater than 2. Technically, if we read these answers as they are, B and C are kind of the same, right? So this here, A, is actually the normal PR interval. Remember, you only had to memorize one number, is 0.2. So anything less than 0.2 is normal. So we can eliminate A and we can eliminate C. So then we have B and D. Technically, these two are the same answer. I had a typo here. This should have been less than 0.1. But here the answer is anything greater than 0.2 is a first degree heart block. Anything over a 0.2 for the PR interval is a first degree heart block. It can be 0.22 and it's first degree heart block. Maybe not serious, but it still is. All right, identify the following rhythm. Sinoatrial block, sinus bradycardia, normal sinus, first degree heart block. Okay. Do we have P waves? Yep. Here's P waves, right? We've got P waves all the way down this strip. Do we have QRSs? Yep. Here's our QRSs. Does every P have a QRS? Yeah, it sure does look like that. All right. Does it look regular? Yes. If we were to march this out, it does look regular. So, do we have, sinus bradycardia, what is the rate of this? This is a 6-second strip, so 1, 2, 3, 4, 5, 6, 7, 8, 9. So we've got a heartbeat of 90, about. So that's normal. So we don't have sinus bradycardia, right? Sinoatrial block is when there's a block occurring in the SA node up here. So that's often like multifocal atrial. The other parts of the atria is firing. So we're going to get rid of that block. So we got normal sinus or first degree heart block. How do we tell the difference between these two? Well, we got to pull out our calipers. So let me get this lined up here. Okay, we're going to add a caliper. We're going to calibrate it. All right, we are calibrated. Let's check out this PR interval. Oh, it's like right at 0.2. Let's get this tweaked a bit. 0.19, that's the PR interval. That's pretty good. Is it less than 0.2 or is it greater than 0.2? It's less than 0.2, so we don't have first degree heart block. We actually have a normal sinus. I just want to see something really quick. I'm really hoping that this works. So this can also check that. That definitely did not work. It's supposed to measure beats per minute too, but it didn't do it correctly. That's the thing I have to figure out with that. So it's normal sinus. So if you guess normal sinus for this one, you're a good guesser. You're going to pass every test just on guessing. All right, identify the following rhythm. Wandering pacemaker, normal sinus with PVC, first degree block, second degree Mobitz type 2. Okay, let's look at this rhythm. We have P waves, right? P wave, P wave, P wave, P wave. We've got, oh, it's late because my brain, it just clicked in my brain. I was double guessing myself. Okay. P wave, P wave, P wave, P wave, QRSs, QRS, QRS, QRS. Does every P wave have a QRS? No. This P wave's missing one, this one's missing one, this one's missing one, and so is this one. All right, so P's are not getting through to the ventricles. So, means we've got a block, so we can get rid of normal sinus. Okay, we can get rid of first degree because not all the P's have QRSs. What if you didn't know what a wandering pacemaker was? We don't really know, we didn't really go over that, right? So it could be wandering pacemaker or second degree block. So we know what second degree block is, right? It's when the P, not all the P's get through, then you have Mobitz 2. QRS is coming home whenever he feels like it. He comes home sometimes the same time every night, and then sometimes he just doesn't come home. That's Mobitz type 2. So we have to look at this. The PR intervals are the same, right? So we've got, if it is second degree, then it's type 2. So if you looked and you guessed second degree, you would be correct because not all the P's are getting through and the PR interval is the same. So if you guess second degree block, Mobitz type 2, you are correct. What is a wandering pacemaker? That is when I was incorrect before. The sinoatrial block is when the SA node doesn't get electrical conductions through, so the AV node completely takes over. The AV node is now the driving pacemaker of the heart. What is a wandering pacemaker? Well, that's when you have ectopic rhythms going on in the atria. So sometimes it's going to come from the SA node, sometimes it might come from the left side of the heart, sometimes it might come from a right part of the muscle. And when you look at your EKG rhythm strips, your P waves are going to look different. Some of them will be upright, some will be inverted, but they don't always look the same. And when you have that occur, then it's a wandering pacemaker. But this rhythm here is second degree block Mobitz 2. All right, this is the last one. No, second to last one, sorry. All right, identify the following rhythm. Torsades, wandering atrial pacemaker, premature atrial complex, third degree block. Let's see. Okay. Identify the following rhythm. So we have P waves, right? Here's a P wave, here's a P wave, here's a P wave. Does every P wave have a QRS? No. But we do have QRSs. So we know that We're not normal sinus. We're not first degree. We could be second degree, right? But look at this QRS. It does not have a P wave. So not all P waves have QRSs, and not all QRSs have a P wave. So let's get our trusty calipers out. I think this is my last question for you guys. Let's add a caliper. Let's march out these P waves. Oh, you know what? I want to add the second caliper. It's easier that way. Oops. So P waves are red. We'll make the QRSs blue. Let's march these bad boys out. Let's march these bad boys out. Okay, so every time we got a red line, we have a P wave. See, P wave, P wave, P wave hitting that T, P wave, P wave. And every time we have a blue line, we have a QRS, 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 QRS. So, if you remember, torsades is a type of ventricular rhythm that it means turning on a point. So it's a polymorphic ventricular tachycardia. So we go down and we go up and down and up. So it's not torsades. Let's get rid of that. We just talked about wandering atrial pacemaker. All your P waves look alike, so that's not it. Premature atrial complex, that's a PAC. It's not that, right? Because we marched out our QRSs and they were all evenly spaced. If you said that this is third degree heart block, then you are correct. Because if you see, all of our P waves march out evenly spaced, all of our QRSs march out evenly spaced, but there's no communication between the two of them. P waves are doing their own thing, QRSs are doing their own thing. So we got third degree heart block. I think that was it. Yes. So, I hope you learned something about heart blocks. I'm telling you, if you remember those analogies, that poem or the analogy, if you think about the electrical activity in the heart with each of the blocks, it's going to make a lot more sense, and you will never miss a block on a test, on your patient. Always use your calipers and have fun with it. I think heart rhythms are a lot of fun. Can't wait to start talking about 12 leads. That's going to be a little in depth, so I may break it up into 2 study sessions. But I hope you learned something. I really enjoyed going over this, and I'll see you next week. Bye-bye. Oh, wait. Make sure you send me messages about what you want to study and stuff. I'll be here. All right. See you next week. Bye-bye.